All right, welcome. I have 7:02 p.m. Eastern, so I think we can get our webinar started slowly but surely. If we haven't met yet, I'm Dr. Melanie Bichard. I'm the current chair of Canadian Doctors for Medicare, and I work as a pediatric emergency medicine physician in Ottawa. And I'm really honored that you chose to spend your evening here with us for what will hopefully be a very fascinating discussion. First, we want to acknowledge that although we are meeting virtually, the Canadian Doctors for Medicare office is located on the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, the Mississaugas of the Credit people. Toronto is within the lands protected by the Dish with One Spoon agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. This agreement captures our responsibility not only to the land, but to each other, which I think is always very relevant to our topics of conversation at Canadian Doctors for Medicare when we're fighting for publicly accessible healthcare. I encourage you to reflect on the responsibilities and relations of the place where you are joining from. And at CDM, we want to recognize the disproportionate and unjust disparities that Indigenous people continue to face today due to racism and the ongoing effects of colonialism here in Canada and around the world. And at CDM, we are really committed to working to reduce these inequities as a key part of our work to advocate for better Medicare. I'll take a moment to pause so we can reflect. And if you'd like to share the traditional territories and lands that you're calling in from, please feel free. Okay. Before we begin, a few housekeeping matters. This webinar is being recorded so it can be shared with those who couldn't join us this evening. Please feel free to send the chat messages to the attendees, and we'd love to hear from you as well. You can ask questions through the Q&A function at any time, and we'll try to get through as many as we can. And I do believe that closed captioning is available and can be turned on as well too. We will run till about 8 p.m. Eastern, so thank you very much for spending your hour with us. Now, the focus of the webinar is that you might have heard that we have a federal election approaching, and there's some ongoing trade tensions with our largest trading partner south of the border. But we are really disappointed to see that even in the midst of all these tensions, there seems to be a shift away from the focus on healthcare in this election in particular. But we know that it is more important than ever to keep healthcare at the top of the national agenda. And our top priorities are to push for primary care reform, address healthcare wait times, advance the development and implementation of the universal pharmacare program, and really oppose a shift towards a multi-payer healthcare system, especially with the pressure coming from the south of the border. In the short term, we are focused on moving two critical policies forward: the full inclusion of virtual care under the public healthcare system, and ensuring continued progress on Bill C-64 and Act Respecting Pharmacare, which lays the foundation for a universal pharmacare program. These campaigns, we've already been working on a great deal in the year past, so we did want to take some time today to celebrate these victories. Bill C-64 did receive royal assent, and several provinces have already signed on. And in January, as you'll hear in great detail shortly, we did receive a Canada Health Act interpretation letter and have brought more healthcare professionals under the public system, meaning that patients can now access their care without needing to pay out of pocket or through private insurance. So this evening is a time of celebrating success, reflecting, and then also using that to pivot and discuss with you what we plan to do in the year ahead as we find ourselves with a new government coming within the next 6 days or so. So today we're exploring those strategies and tactics to grow the movement, and we'd love to share those with you. Without further ado, I will introduce my colleague, Dr. Bernard Ho, who is the Vice Chair of Canadian Doctors for Medicare, as well as an emergency physician and family physician in Toronto. Bernard, take it away.
Perfect. Thanks so much, Mel. Let me just share my screen here. So I'm going to briefly speak about pharmacare first, and then I'll pass it back to Mel. So I want to talk about pharmacare and how we got to where we are today. So firstly, I just want to talk about or give a brief overview of why we even care to advocate for national pharmacare. The issues come up so many times over the past few decades. We firstly had the Hall Commission in 1964 that recommended implementing federal legislation around national pharmacare. Then 30 years later, we had the National Forum on Health that recommended the same thing. In 2002, we had the Romano Commission. In 2018, we had the Parliamentary Standing Committee on Health. And most recently, in 2019, we had the Advisory Council on the Implementation of National Pharmacare, all recommending, again, the same thing, comprehensive, universal, single-payer pharmacare. And as one of our former board members once said, if only our patients could pay for their medications with pharmacare reports, then we would all be okay. And part of the issue is that our drug expenditure has been steadily increasing since the 1980s, and drugs have consistently been the second largest component of our healthcare spending for the last nearly 3 decades. And when we look at other OECD countries, we spend about 30% more on drugs on a per drug basis. And until very recently, Canada was the only country with a universal healthcare system that didn't have a national pharmacare program, which isn't a title that we really should be proud of. When we look at data from 2021, this shows the public-private split of various healthcare services. So remember that the hospitals and physicians are covered under Medicare and are under the umbrella of universal healthcare. So that's why the majority of that expenditure for those services fall under the public sector. But we can see with prescription medications that there's a somewhat even split between the private sector and the public sector spending, slightly favoring the private sector spending. But the reason that there isn't an even bigger skew towards the private sector is that public sector share accounts for medications that are prescribed in hospital, which again, due to Medicare, is covered. And so this graph from CIHI, or the Canadian Institute of Health Informatics, shows how our drug spending has changed since 1985. And you can see that on the left-hand side, that on a per capita basis, our spending has gone up significantly from about $100 per capita to almost 10 times that in 2018. And similarly, the costs of drugs as a share of our GDP has also gone up from about 0.5% of our GDP to triple that to 1.5%. And this is again 2021 data, where Canada ranked fourth in per capita drug spending. So across the entire world, uh, Canada spent the fourth most on prescription medications behind US, Germany, and Japan. And that's actually somewhat lower than historic, which usually we've alternated between the second and third place. And part of the change for that is because of COVID. But currently we spend about 868 USD per capita on drugs compared to the OECD average of 571 USD. And the consequences of all of this is seen in this 2020 Angus Reid poll that looked at the attitude and behaviors towards high-cost medications. Now, almost a quarter of Canadians decided not to fill or renew their medications because of cost, or did something to make them last longer, which would include cutting tablets in half, skipping days for medications, so taking their medications every other day. And you can imagine the downstream effects of heart disease, of poorly controlled diabetes or asthma, and other chronic illnesses because of these decisions that have to be made. And that brings us to more recent developments. In the past years, we've seen the first real step that the federal government has taken towards pharmacare. In March of 2022, the Liberal Party, in partnership with the NDP, announced their Supply and Confidence Agreement, which, among other measures, prioritized a better healthcare system, and in particular, a pharmacare program. What they promised was to pass a Canada Pharmacare Act by the end of 2023, and task the Canadian Drug Agency to develop a national formulary and a bulk purchasing plan. And this brings us to Bill C-64, which is an act respecting pharmacare. And while it's taken a couple of years since the formation of the Supply and Confidence Agreement, Bill C-64 went through its 3 readings and received royal assent in October of 2024, which is a little bit later than what was promised, but it made it law in Canada. So what does Bill C-64 actually cover? It covers contraceptive medications and diabetic medications and devices. And importantly, it recommends that the program should provide universal single payer first dollar coverage for those medications, even though it doesn't explicitly commit to that. It also recommends the development of a national formulary for essential prescription drugs and related products and the development of a bulk purchasing strategy. And it states that within 30 days of receiving royal assent, the government must establish a committee of experts to make recommendations around the operation and financing of a universal single-payer pharmacare program. And importantly, the model that the federal government chose for long-term funding of the pharmacare program is contingent on bilateral agreements with the provinces and territories. This means that the program will look slightly different between provinces and territories, and that the premiers must first come to the table to negotiate. And so far, we have bilateral agreements signed by 4 provinces and territories in BC, Manitoba, PEI, and the Yukon. So what has CDM been, doing during all these years? We've been pretty busy. Pharmacare was one of the main reasons why CDM was founded. So we wanted to capitalize on this historic moment. We've written numerous op-eds targeting both the public and policymakers on the benefits of a universal single-payer pharmacare program. We met with the previous federal minister of health, Mark Holland, to discuss pharmacare and other healthcare concerns, and we continue to meet regularly with staff from his office in charge of the pharmacare portfolio. We submitted a brief to the Standing Senate Committee on Social Affairs, Science, and Technology, which urged the Senate to pass the bill as quickly as possible, while also making recommendations on the precise language used in the bill to ensure that the program was truly universal and not a fill the gaps approach. We also submitted a list of pharmacare experts to the federal government, and we're pleased to see that many of them made the list of the committee of experts. And we organized a lobby week where many CDM members reached out to their local MPs to explain to them the importance of passing a bill and ensuring that it remains universal and single payer. So what are the next steps? Well, we still need bilateral agreements between the remaining provinces and territories, and we're actively advocating regionally towards this. We'd like to see the expansion of this program to cover other medically necessary drugs, and that's where the national formulary comes in. Regardless of the outcome of next week's election, we'll work with the newly formed government to continue to push for this historic legislation. And we'll continue our education initiatives and work with other allied organizations like the Canadian Health Coalition, the Canadian Medical Association, the Canadian Federation of Nurses Unions, to advocate for single-payer pharmacare. And with that, I'll pass it back to Mel.
Thanks very much, Bernard. Okay, I'll share my presentations as well. Perfect. Okay, I'm here to talk about the Canada Health Act interpretation letter. I think that many of us have a bit of an innate understanding of pharmacare and what it is, but if you've read your CDM emails, even a little bit, no worries if you haven't, you've probably heard us talk about this letter. And it's been very hard, I think, for us to communicate to a lot of the public and a lot of my colleagues working in medicine why I get so excited about this promise of a random policy letter. Now, I understand those of you here are probably keyed in and just as excited as us, but I want to make sure that the concept becomes really clear. So way back in March 2023, something really major happened. Taylor Swift announced her Eras Tour. So that ran from March 2023 until December of 2024. And it was an absolute historic moment. But what most people might not also know is that in March 2023, we also had a historic moment where Jean-Yves Duclos, who was the health minister at the time, promised to issue an interpretation letter on the Canada Health Act. So this announcement came relatively quietly, but this letter was huge. It essentially promised that virtual care, telemedicine, and the expanding scopes of practice of healthcare workers like nurse practitioners and pharmacists should really be considered to be brought under the Canada Health Act and under the public umbrella, because these areas were not necessarily explicitly mentioned in the 1984 Canada Health Act for obvious reasons. Virtual care was not as big a way of delivering care back in 1984. We did not see the same scopes of practice for other healthcare professionals as we do today. And that's why some folks have been able to try and exploit this to justify charging patients or charging private insurance to cover these services. But through pressure from groups like Canadian Doctors for Medicare and many of our allies, the health minister at the time recognized that this is a concern and does deserve some clarification. So we did have this commitment that it is critical to access medically necessary services, whether provided in person or virtually, remains based on medical need and free of charge. That's our core values, and that resonated with us. And it's so exciting to see a federal minister sharing that. We see these promise here to clarify in a separate letter that no matter where in the country Canadians live or how they receive medically necessary care, they must be able to access these services without having to pay out of pocket. So reading this back in March 2023, I think instilled within many of us a great sense of hope. We were very eager to see this letter issued. We're very eager to see these gaps in our system plugged. So that way we wouldn't have what is essentially becoming slowly but surely a two-tiered system when it comes to being able to, let's say, pay a nurse practitioner to be your primary care provider, or pay to see a physician virtually, but for some reason not in person. Well, what happened? We waited and we waited and we waited with bated breath for the release of this promised interpretation letter. But nothing really came of it. And Minister Duclos came and went from his position, and Minister Mark Holland took over. We were able to organize monthly meetings with one of the staff members in the Minister of Health's office, who was in charge of the Canada Health Act interpretation letter. So we were able to get direct updates, kind of keep that pressure on just for that shared accountability, and share why this is so important to us as frontline care providers who are seeing patients who are asking us questions about why they need to pay to have a nurse practitioner deliver their primary care, or how come they can come to the emergency department and it's covered, but not use a virtual care service and necessarily have it covered in the same way. So through those shared concerns and building of a relationship, we're able to eventually get to a point where things looked very helpful. And in July 2024, we were told any day now the Canada Health Act interpretation letter will be released. But then there was still silence. So what were the barriers? Now, there's a few that we can surmise quite readily, the private insurance industry. And this makes sense. If virtual care, or let's say nurse practitioner care, is something that can be sold as part of a private insurance package, it's something that they can profit off of. Whereas if these services are already publicly funded and publicly covered, there's going to be less opportunity for the private insurance industry to be able to sell that. People aren't going to necessarily buy something or pay more for something if they already have access to it through their health card. This became clear to us. We can see from the Canadian Chamber of Commerce, this is a screenshot taken from their website just a few days ago, showing how they're trying to purport that having publicly funded virtual care would actually hinder your access to employer-paid virtual care, which is true in a way, but it's not true in that it would limit your access to virtual care. It would change who pays for it. And I think for my patients and for myself, I might not care so much if that virtual care is paid for by the government instead of by a private insurance. I just care that I can still access it. So suffice to say, we are seeing some pressure from insurance groups, from the business community, that were kind of lobbying some key parliamentarians to try and prevent this letter from coming through. We also heard as well that there might be a little bit of pressure from the Prime Minister's office to not release the letter. It's difficult to say why. It might just not have been a priority for Prime Minister Trudeau at that time. Apparently, there might have been some hesitancy and reluctance upon the part of the provinces, the federal government dictating that now these additional health services need to be publicly funded does involve some great deal of work on the part of the provinces and territories to then start publicly funding those services. So maybe there is some concern about tensions between the different levels of government. In any case, we found these barriers really delayed the release of the letter. So that was a bit disappointing for us, but of course we had to go back and create a bit of a strategy. We worked with a great communication specialist by the name of Chris Holcroft for a few months from September to November in 2024, and slowly escalated. We engaged in a great deal of op-eds and interviews on the matter. We tried to keep it present in the media. We were able to try to meet directly with the Prime Minister's office. I said we were able to try. We never actually got a meeting, but we were quite dogged and reached out to a number of different folks in the Prime Minister's office, who always would respond to us and say that they're working on the letter and then would direct us back to the Minister of Health's office. We were more effective, I think, in keeping the issue in the media. And for anyone here, if you're ever wondering how to keep a policymaker, a politician accountable to their promises, the media is a great way to do it. And I should note as well, too, it seemed as though the Minister of Health's office was on our side. They were interested in issuing this letter, but they were maybe feeling some pressure from those external forces. However, by continuing to raise the issue, it allowed them to continue to advocate and share with their party, look, people actually care about this letter and we can't just let it fall to the wayside, as unfortunately so many promises often do. When we were able to keep the issue active but weren't actually seeing the change we wanted, we then worked with Chris and with our colleagues at the Canadian Health Coalition to organize a press conference. And I do think that this might have been a turning moment for us. Now, take that for what you will. It might be self-serving because I was able to participate in that press conference wearing my doctor outfit there with our colleagues, Steve and Anne from the Canadian Health Coalition. And the press conference saw a renewed push in the media. We were told from our contacts at the Minister of Health's office that it was very beneficial for helping them with their own advocacy to get the letter through and help to reinvigorate that initiative. And I also have to thank many of our webinar regulars who attended our Phone Zap webinar. I believe that this was in early December, where we spoke about the Canada Health Act interpretation letter and had many of you reach out to your representatives. So that was a great deal of work that we had from November through December. And then on January 10th, 2025, we got what we wanted, kind of. So for those who are unfamiliar, there was a letter issued from Minister Holland's office on January 10th, 2025. It's the long-awaited Canada Health Act interpretation letter, which we're very excited to see. It references this new Canada Health Act services policy, which, when you look at it, says, when the policy is implemented, patient charges for medically necessary services, whether provided by a physician or other healthcare professional providing physician equivalent services, will be considered extra billing in user charges under the Canada Health Act. What does this mean? Well, it means that now when I have patients who are desperate to have a primary care provider and they go to nurse practitioner run clinics, for example, starting in April 2026, they will be able to access that care using their health card, using their publicly funded government plans, rather than having to pay out of pocket or use private insurance. So it can dramatically expand access to care for those patients. Other healthcare professionals specifically mentioned included pharmacists. We do see, especially in my province of Ontario, an expanding scope of practice of pharmacists who are able to diagnose and treat certain conditions and prescribe. Now, I think that at CDM, we don't really take a stance on the best way to use the different scopes of different healthcare professionals. I think our main concern is that when healthcare professionals are providing these care, we should make sure that there's not a two-tiered system and that there is equitable access. So all in all, this was a great win. I think this is good news. I'm in Ottawa. We do have nurse practitioner run primary care clinics that are currently charging patients. This is something that will change over the next year or so. However, there's some disappointment there, because if you're really astute and tuned in, you'll notice that this policy and this interpretation letter really says nothing about virtual care. So we're still left in a situation where we don't necessarily have clarification on whether or not virtual care should still be included within the Canada Health Act. There's still more pressure and still more work to be done. We've spoken with our contacts about why this omission occurred. It sounds as though largely due to some of the pre-existing barriers and the pressure from the private insurance industry and from corporations that do have a lot to lose if virtual care is brought under the public umbrella. But what are our next steps to make sure that we're really closing these gaps in care? Well, we're going to continue to try and keep these longitudinal relationships with policymakers. We are a small organization at Canadian Doctors for Medicare, but I think we've been able to affect real change by forming these relationships and by always trying to be solutions oriented. Even when we disagree with policymakers or their staff, we always try to think about our shared values and how we can work together. And I think that's why we keep getting invited back and why we've been able to see some real movement on some of our items. At the end of the day, policymakers are people too. And I can say with confidence that no matter what the outcome is of the election happening next week, we will be very eager to work with those in power to try and affect our change. Our strategy might change depending on their political background and beliefs, but we're always going to try to work to advance our values. Now, we've also spoken with some of our contacts in the political sphere, as well as some contacts in different government agencies. And there is a possibility that virtual care might be able to be brought under the public umbrella without an explicit letter. It's a bit complicated, but if you look at it at face value, it doesn't really make sense that we need a whole letter to specify that, okay, if you see a doctor in person, it'll be publicly covered, but if you talk to them over the phone or virtually, it won't be. It doesn't really make sense. And there's some thought now that even the interpretation letter on January 10th didn't specifically mention virtual care, the scope of the letter and the intent of the letter should be clear enough that this might be something that could start to be enforced. So stay tuned. We're going to see whether or not our advocacy pushes towards including another letter or whether or not we might be able to just close these gaps in terms of access to physicians. And we always want to highlight the problems with access to two-tiered healthcare. We want to make sure that we're advocating for access to equitable, evidence-based care as much as possible, high-quality care, and that whenever you have a system where some people are able to access care through private insurance or out of pocket and others are not, it does create a disparity, and that's not a good way to spend our healthcare dollars, and really not consistent with the values of this country for so many of us. If you're interested in references, I can copy and paste and put a few of these into the chat, but you can also screenshot this and take a look. We have a great deal of information on this interpretation letter campaign on our CDM website. Now you know it's not just a dry policy letter, but it has real impacts on our patients in expanding access to care. You can read the original 2023 announcement. You can also see our press conference video if you want a really exciting 5 to 10 minutes added to your life. And then the Canada Health Act interpretation letter that was issued in January is also available too. Here's some quick photo credits. I'm a very visual person, so I hope you liked the pictures. And I'll now turn it over to Bernard to kind of walk us through our next steps and what we're planning to achieve with the new administration in a post-election realm.
Thanks, Mel. Yeah, so I mean, regardless of who wins the election next week, we're going to continue our agenda for public healthcare reform, and we're going to continue to push the policies that better our public healthcare system for everyone. And so beside pharmacare, which we talked about, and the Canada Health Act interpretation letter, we've also pushed for other primary care or public healthcare solutions like centralized referral systems, better utilizing our allied health specialists so that patients can see specialists quicker, multidisciplinary teams, primary care reform, and addressing other healthcare wait time concerns by expanding operating room access, and ensuring that we don't continue to lose more physicians and providers to the private healthcare system. And again, also many of the next steps that we talked about with pharmacare as well. And I think Mel will talk about some of the other strategies that we're using more so on the defensive side.
Yeah, exactly. At CDM, we never want to be seen as defenders of the status quo because, let's be honest, the system is not working in its current form. But our position, based on the evidence that we're familiar with, as well as our frontline experience, has always been that the way to fix this broken system is not to start charging people out of pocket for care. The way to fix our system is to do everything that Bernard mentioned, to expand the public basket of care, to fill the obvious gaps that we have in our system, to really focus our efforts on improving and supporting primary care. Even though I work exclusively in an emergency department, I think if I had one wish for the healthcare system today, it would be to have everyone have a family doctor. It wouldn't be to increase primary, or it wouldn't be to increase emergency physician salaries or to improve anything in the emerge, because I know that my job in the emerge becomes much more manageable, much easier when my patients have access to like a longitudinal primary care provider who can actually see them and follow up and learn their healthcare issues. So we're really key at trying to improve the healthcare system, but at the same time, we recognize that we have to play defense as well too, that there are a lot of corporations banging down our doors, especially now as We have certain individuals claiming that we might become the 51st state, who are eager to try and profit off of the deficiencies that we have in our system and to profit off of the desperation that patients have to seek care. So some of the things that we're looking into is really keeping an eye on Canada Health Act violations. There is a section on our website whereby if you find that there is a clinic or healthcare provider in your region that you feel is violating the Canada Health Act by charging people directly for care when perhaps they shouldn't be, we have per province and territory how to report that and how to escalate that issue. We think that that's really important. We also want to explore more this issue of private equity entities that are coming into Canada and taking up a larger share of the market. We will have, in the next month or so, a position statement on private equity released. And if, like me, you're not an economist, it does kind of walk you through what these private equity corporations are, how they make money, and why we're so concerned about their incursion into Canadian healthcare. So stay tuned for that. We have future webinars coming up later in the late spring, early summer as well, just focused on private equity, because this is something where we feel as though we don't hear a lot of other individuals raising the alarm in Canada yet. We've had a few astute economists who are raising the alarm, and we're really trying to showcase from a healthcare provider side why we're worried about these corporations. And we also want to make sure that we're continuing to close the gap between those who have workplace insurance and those who do not, which is why we do believe that single payer universal healthcare tends to be most effective. Our theory of change to try and achieve these going forward is trying to use our clinical frontline experiences to educate both with the public, folks like yourself, other healthcare providers, and also especially policymakers about how we can actually improve healthcare and how we can defend what we do have. And again, no matter which party comes to power, CDM will be a united force for public solutions. We know that this is more important than ever because we do have those private equity companies, insurance companies, and proponents of for-profit investor-owned care actively working to push healthcare in our market. And unfortunately, if they do succeed, the significant challenges that we see today, we can only imagine will intensify, likely for everyone, but especially for those who have fewer resources and have fewer access to care. So even though those with deep pockets are trying to take away healthcare from the public system piece by piece, we do remain steadfast in our mission to try and defend and improve that equitable access, high quality care for all. So at this point, you've listened to us drone on. We have ample time for questions. I do see some lovely chatter in the chat here. We have Anne Rothman sharing experiences from Quebec, where there seems to be a bit of a disparity, where there is publicly funded virtual care, which seems to be a huge success, agreed, but then also physicians who are also practicing private telemedicine as well too. And we should mention that there is definitely some public funding for virtual care in every province, but there tend to be a lot of gaps. So in Ontario, typically it's publicly funded if you're in a longitudinal relationship with a healthcare provider. The code can sometimes be less than you'd see for in-person care. So it does limit access a little bit and does create some stipulations there.
And I'll speak to Anne's comment too about Quebec. My understanding is that Quebec is a little bit unique in that physicians can easily jump in and out of the public and private system. There's just a few week cool down before they can go back in. So many physicians will jump between both systems several times in a single year. And part of that's part of the problem where they're both under the public system of Medicare, when they're treating patients under the public system, but at the same time they're charging patients out of pocket in a separate month for virtual care, for other medically necessary services. And that's led to a lot of issues, especially around primary care, where we're seeing a lot, or Quebec is seeing a lot of new grads and primary care physicians leaving the public system and going into the private system, which is something that we're continuing to advocate against and to try to improve on the public system.
I see a comment as well in the chat from Catherine Bennett about how CDM should consider advocating for healthcare to be included around interprovincial cooperation and removal of provincial barriers to the provision of medical care. Catherine, I couldn't agree with you more. Living and working in Ottawa, it is essentially a border town because we're right on the border of Quebec. And in the emergency department where I work, about a third of our patients are RAMQ patients, meaning that they have the Quebec public insurance. Now, for our hospital in particular, there is a pre-existing agreement set up where we are able to accept the RAMQ payments readily, and it's generally not an issue. But we do not see that everywhere. And we do see that there are issues sometimes with provinces refusing to cover treatment for others. Now, this is not really justifiable. One of the key tenets in the Canada Health Act is portability, basically meaning that you should be able to have your care covered wherever you are in the country, regardless. If I am on a trip in Winnipeg and I need to go to the emergency department, that should be covered just the same as it would as though I had to go to the emergency department here in Ontario. We do see that some individuals are trying to exploit this. I can't even call it a loophole because it's not a deficiency of the Act. I think it's just a deliberate misinterpretation where some folks are saying, well, if you come have surgery in, let's say, Alberta, if you're from Ontario, technically you're not on the Alberta health plan, so you're not health plan covered, so I can charge you for it. And sometimes people are trying to use this as a way to jump the queue for surgery. And unfortunately, it's really not justifiable. We are bringing up instances of this to our colleagues at Health Canada, especially the Canada Health Act Division of Health Canada. Again, if you see instances of this, Zarif, our national director, is putting a lot of links in the chat for how you can report that.
And I see that Zarif also asked the question about pharmacare, about Bill C-64. So can the new government overturn Bill C-64s? So because of the bilateral agreements with several of the provinces and territories already, it becomes a little bit harder, which is why we are advocating for these bilateral agreements to happen with the other provinces and territories as soon as possible. It's not an impossible situation for the new government, whichever government it is, to overturn Bill C-64, but the bilateral agreements to provide a layer of protection. Can we go from, the other question was, can we go, if it's not canceled, can we go from universal to fill the gaps approach? And so again, that is another risk. If a new government is formed and they don't agree with Bill C-64, our perspective is that the pharmacare program should be universal, single payer, and it shouldn't be a fill the gaps approach, which means that pharmacare it would only be covered for those who don't already have necessary coverage under private insurance or through their employer. Our view is that pharmacare and prescription medication should be covered for everyone, regardless of where you work or what your employment status is or how old you are. Medications and health are a human right.
Yeah, and I can add on that too. Our position on the pharmacare situation is that we're really trying to push through some of these bilateral agreements. As Bernard mentioned, some provinces have signed on, but not all and not a lot. And it is very easy, or at least easier, for politicians or parliamentarians to take away something that people haven't experienced yet because it's theoretical. However, once these agreements actually start to get medications into people's pockets, once they start receiving their publicly funded diabetes medications or contraceptives, that would be arguably a lot harder for a politician or parliamentarian to take away. Because at that point, people have experienced it, they've received their medications. So we're really trying to ensure that these agreements are signed quickly, that they're put into action, because once people get used to having these medications, I think it'd be a lot harder, probably not impossible, but a heck of a lot harder for somebody to come in and dismantle the program. So for those of you in the Atlantic provinces, I think we're going to do a specific push and work out there to try and see if we can convince the Atlantic and Maritime provinces to consider signing on. Many of us in our CDM leadership right now are based in Ontario, and we're also looking at maybe an Ontario push later this summer too. So we're doing our best. If you're very interested in helping us with that, please feel free to reach out. We always want to make sure that we're mobilizing our membership since we are decently represented coast to coast to coast. Any other questions or comments or sharing your experiences, advice you have for the organization as we look into 2025 and beyond in a post-election world?
or anything else that you would like to see us do after the election as well.
We do have one question that's come in. Let me see. Oh, here we have a few coming in now. Thanks very much, everybody. I see from Geraldine Pryor. Are you getting pushback from pharmaceutical manufacturing companies who will be getting lower prices for medicines once there's national distribution evaluation? I'm thinking of oral micronized progesterone. We ourselves haven't been directly getting pushback from pharmaceutical companies, but the big pharma lobby is indeed a big opponent to pharmacare for exactly those reasons. Joel Lexchin is one of our board members, and if you've read any of his output in the media or in academic journals, he very clearly outlines a lot of the problems with the pharmaceutical industry and how there's really this narrative that drugs need to be expensive because most drugs that are tested don't necessarily make it to the market, which is true. But the challenge is that when you look at how pharmaceutical companies spend their money, a great deal of it is actually on marketing rather than research and development. A lot of the initial research and development for pharmaceutical medications actually happens in universities and in public institutions. So it's not as though they're shouldering all that research burden in and of themselves. Having a universal pharmacare program would allow us to negotiate drug prices lower to buy them in bulk. It's the same principle as to why it's generally cheaper to shop at Costco and to buy your toilet paper in bulk rather than to buy your toilet paper one by one, roll by roll from your local convenience store. So that, of course, having lower drug prices is great for the Canadian healthcare system, the Canadian government, but not great if you're running a pharmaceutical company and trying to make a profit. So you're absolutely correct in that they have a powerful lobby, they have been opponents, and they are, I think, one of the groups that we're stacked up against, unfortunately, when we try to advocate for pharmacare. Do you have anything to add there, Bernard?
No, I think you answered that beautifully. I
We're
see
both
another
long-winded here. I see.
question.
Oh yeah, go ahead.
Sorry. All right, I just see another question in the Q&A from Sheila, or a comment, better income security so people don't get sick. And again, totally agree. We work with a lot of our allied health organizations to advocate for improved working conditions, for paid sick leave, for improving our minimum wage. So in Ontario, for example, the Decent Work and Health Network is one organization that we continue to work with and partner with to advocate for better income security, especially for our marginalized populations and those who have to work multiple part-time jobs, who don't necessarily have employer benefits, so who may not get their medications covered currently because of their employment status, and that's a huge barrier to healthcare access. So, agree with you that it's a huge problem.
We have a question from Faye McKay. Why is TELUS being allowed to monopolize so much of our medical care, EMRs, virtual care, et cetera? They are completely profit oriented. Is that being addressed anywhere? Excellent question. You know, we're seeing it from TELUS. TELUS is not the only organization that does seem to be moving towards providing healthcare in different ways and being one of those for-profit investor-owned corporations. For those who are curious about some of the terminology we use, we do have a Mythbuster on privatization and explainer on our website that kind of goes over these different terms. And we do get concerned when we see for-profit investor-owned corporations moving into healthcare spaces because so much of the time that focus does shift away from the patient and shifts towards profits and accountability to shareholders. Not to say that there is not any role for these companies. I think maybe in the creation of technology, TELUS can provide a lot there. But for the actual delivery of healthcare, that's where we do start to see some concerns. And that's not to say just TELUS. I think there's a number of corporations that would love to be in this space that are slowly making their way into this space. And I think that's because they realize that there is a huge need and a huge gap. People are desperate. I would never judge anyone for using an app like TELUS or Maple or seeking healthcare at Loblaws or by their pharmacist or paying for a nurse practitioner, because when you have no other options, people will open their wallets. I think it's just such a shame that there are all these excellent, innovative ways of delivering care, and we're looking into these new models, but unfortunately, we're only making them available to those who have private insurance or who can afford it. So, nothing against TELUS personally, but when it comes to healthcare, I do think that we need to look at expanding our public system rather than relying on corporations to try and fill those gaps, because we've just not seen it be successful in other countries or in instances in Canada. Anything to add there, Bernard? I want to make sure it creates space too.
No, that's great.
Yeah, I see
And
Jerrilyn adding a comment in the Q&A too about how Merck Frost got the marketing rights for Prometrium about 2 decades ago, and at the time it cost $1 for about 300 milligrams per day, and it now costs almost $6 per day. Yeah, some of the inflation we're seeing is just over the charts. I don't know what Prometrium is. I don't think it's a common med of the pediatric emergency department space, but yeah, we're not alone in that. And I think we've seen similar moves south of the border with respect to insulin charges. We know that these drug prices are not always related to the actual cost of making and manufacturing the drugs, but rather sometimes to how much the companies can profit off of them. Bernard?
yeah, Prometrium is progesterone.
Oh, perfect. And I see Catherine writing that it's a good idea to approach local MPs. Yeah, thank you. Oh, and thank you, Tati Hendry, who said, I can't see the other chats, but thanks for all the good work getting as far as we have. And then Catherine is saying, is it true that the federal government can deliver healthcare as long as it is directly to individuals with respect to the Constitution division of powers? This is, I think, controversial. I think you would probably ask, 5 different policymakers or 5 different lawyers and get 5 different responses. We do know that the federal government does and can deliver healthcare to specific groups. Sometimes the indigenous population, military, sometimes people in federal penitentiaries are specific groups that have federally funded healthcare plans. Refugee claimants are also often in that category. So it's not completely unused to delivering healthcare. I think one of our challenges as a national organization, though, is that whenever we do approach the federal government about a health issue, it can be very easy for them to say, talk to your province or territory. And then when we go to the province or territory, they'll say, well, the federal government is our funders, go speak with them. So sometimes there is that lack of clarity. I think it's like anything else. Any of us working in the medical field who have tried to, consult a specialty for a patient who, maybe they have a lesion that could be seen by gynecology, or maybe dermatology is better to see the patient. It depends on whoever you call, but sometimes we'll say, oh, call my colleague instead. So I think that's where we do see these issues arise. Where we've seen successful programs happen, though, is when the federal government has been able to create a national program that allows the provinces and territories to buy into it and to agree to it. So that's what we saw with Medicare initially. Medicare did not happen for the entire country at once. It was a federal program that the provinces and territories signed up for and agreed to. They had to meet certain stipulations, and then the government would provide some funding and cost sharing to help cover the cost of the medical care. So it's very similar to how Bill C-64 and Act Respecting Pharmacare is set up. So could the federal government deliver healthcare directly to individuals? It does in certain circumstances. It can probably do some more. Do I see that being a more prominent way of delivering healthcare? Not necessarily, but do I think the federal government has a role in establishing healthcare in Canada, reducing disparities between provinces, leveraging its purchasing power to fund some of these big programs? Absolutely.
One of the programs that I can think of that is a federal health program is the Canadian Dental Care Plan, which is a federal program that provides dental care to all Canadians in certain age groups. But it does work in conjunction with the provincial programs like ODSP or the Ontario Disability Support Program. So it's not fully federally funded and federally delivered. And we know from meeting with staff from the Minister of Health's office is that the federal government really does not like to overstep their jurisdiction around healthcare. They really like to work with the provinces and territories around healthcare programs, like Mel said. Although they do have some levers around the Canada Health Act transfers to try and get provinces and territories to utilize the funds that they provide them for healthcare in a way that actually benefits all Canadians.
Thank you for all the engagement, everybody. If you have other questions or suggestions, I think we do have time for a few more. But also for wrapping up, we're not going to keep people here longer than their will. I don't know anyone who's ever upset about a little bit of extra time unexpectedly in their day. Well, maybe we'll start our wrap up. And if anybody does really want to stick along for those extra 7 minutes, maybe like a smaller group to ask your questions, we can definitely stay on for a little bit longer. So I just wanted to say thank you so much, everyone, for joining us tonight, for having an engaging conversation. For any questions that do come through last minute that we don't get a chance to answer, we'll do our best to provide those answers in a follow-up email for you. Thank you very much, Bernard, for spending your time tonight and giving us a key update about pharmacare, one of the key core campaigns that CDM's been working on. I think since I was a medical student and beyond, it's one of the campaigns that drew me to Canadian Doctors for Medicare. And it's so cool that in a relatively short amount of time, I think only 10 years since I graduated medical school, that we're seeing real movement towards a program. As imperfect a bill and as limited a bill as C64 is, I think it'll be really great to see patients starting to receive diabetes meds and contraceptives, hopefully within the next few months. As I mentioned earlier, if you're a medical student or resident, practicing a retired physician, and you're not yet a Canadian Doctors for Medicare member, please consider joining today. Our website is canadiandoctorsformedicare.ca, and I know our National Director, Zarif, has been sharing all those links in the chat. And for everyone else, please also consider signing up to our newsletter for future updates, invitations to events like this. I think it's a great way to learn something new and to even just receive that validation that there's other people in this group and in this country who think similarly to you, who value equitable, accessible public health care. We know that there is strength in numbers, and it's only by coming together that we're able to really bring about this change. We know that we have a lot of passionate, knowledgeable guests in this audience. I'm always floored to see some of the celebrity names that we have here, or at least I think you're celebrities in the health policy advocacy space. And we look forward to continuing to work with you to strengthen and improve our healthcare system. Again, if you'd like to donate, join, or support Canadian Doctors for Medicare, there's links in the chat. Thank you so much for your kind words. Thank you, Faye. Thank you, Anne. Thank you, everyone. Have a lovely evening.
Thank you all.